regorafenib or trifluridine chipiracil, also known as TAS-102, a standard treatment option for patients with metastatic colorectal cancer, with median PFS of approximately 2 months and a median OS of approximately 7 months. In the phase 2 LEAP-005 study, Lenvatinib plus pembrolizumab had promising anti-tumor activity with manageable safety in patients with previously treated non-MSI metastatic colorectal cancer. So based on the promising result of the phase 2 study, we conducted a phase 3 randomized LEAP-017 study of Lenvatinib plus pembrolizumab versus standard of care with regorafenib or TAS-102 in patients with previously treated non-MSI metastatic colorectal cancer. So the eligible patients were adults with non-MSI or not mismatch repair deficient metastatic colorectal cancer that progressed on or could not could not tolerate standard therapy. A total of 434 patients were planned to be randomized to receive either pembrolizumab 400 mg every 6 weeks plus Lenvatinib 20 mg once daily, or investigator choice of standard care therapy chosen before randomization. So randomization was stratified presence or absence of liver metastasis. So the primary endpoint was overall survival, and the secondary endpoint was the progression-free survival and objective response rate by central review. So the protocol had specified one interim and one final analysis. The final analysis of OS was performed after 336 days and 7 months after interim analysis had occurred. The overall type 1 error was controlled at the one-sided alpha of 2.5%, or was allocated to OS. The PFS and OR hypotheses were tested only if the OS null hypotheses were rejected. Baseline characteristics were largely well balanced between the treatment groups. Approximately 70% of patients in either treatment groups had liver metastasis present. 35% of patients in the Lenvatinib plus pembrolizumab group and 40% in the SoC group had a PD-L1 CPS 1 or more status. And 58% of patients in the Lenvatinib plus pembrolizumab and 54% in the SoC group had a RAS mutation. And the proportion of patients who chose regorafenib or TAS-102 before randomization was similar among the treatment groups. So at final analysis, overall survival was longer with Lenvatinib plus pembrolizumab versus standard care, with median of 9.8 months versus 9.3 months. The hazard ratio was 0.83 with p-value 0.0379. Unfortunately, it did not meet the pre-specified threshold for statistical significance. Also, at final analysis, median PFS was 3.8 months in the Lenvatinib plus pembrolizumab group versus 3.3 months in the standard care therapy group. The hazard ratio was 0.69. Although this was not formally tested according to the multiplicity strategy, objective response was at 10.4% in the Lenvatinib plus pembrolizumab group versus 1.7% in the SoC group, with percent difference of 8.7%. The median duration of response was 11.1 months versus 7.6 months. So the treatment-related AE occurred in the 95% of patients in Lenvatinib plus pembrolizumab group versus 86% in the SoC group. So most commonly hypertension, proteinuria, and hypothyroidism. Grade 3 or higher treatment related to AE occurred in the 58% versus 42% of patients. So in summary, in the phase 3 LEAP-017 study, although there was a trend toward longer OS with Lenvatinib plus pembrolizumab versus standard of care therapy at final analysis, the combination did not meet the pre-specified threshold for statistical significance for the OS primary endpoint. There was also a trend toward the improvement in the key secondary endpoint of PFS and objective response rate with Lenvatinib plus pembrolizumab versus standard of care. No new safety signals were observed, and the safety profile was consistent with that previously reported for the combination. The novel treatment-related option for patients with previously no MSI metastatic colorectal cancer remains unmet medical needs. In the LEAP-017 study, the biomarker analysis was conducted gathering the tumor tissue and the blood specimen. So we should predict biomarker for this combination in the future development in the immunotherapy for MSS colorectal cancer.